So ideally, I will put my probe over here for subgluteal. But I cannot really see well. So that's why I'm now tracing the nerve distally. I know that if I have her prone, obviously cannot do that. I will be able to follow it from the popliteal and all the way up. That would be the way. If you have any difficulty finding the nerve, that would be the best thing to do. But right now, so as you can see, is quite fuzzy, right? Everything is fuzzy. Even the muscle texture is not so clear. So you definitely see bone. Bone is the structure, curved line. That is bone, right there. And now I am looking for something very bright, and it will be intermuscular. So we decrease because the nerve is very bright, so you don't want to have overgain, because otherwise you will not be able to see it. So I'm still not very sure where you see the arrow there, maybe. So this is the challenge with ultrasound. Whenever it's something deep with a lot of adipose tissue in the back, and the resolution is not so good, it's not easy. In fact, can I just try the linear probe and see what I actually see? Because I have a hard time differentiating the fuzziness. If you can just put on the tegaderm, I'll just use that too. So whenever I have really trouble like this, the best thing is put the patient prone, scan. I know I can see the popliteal sciatic nerve, and I scan proximally, as high up as possible. So let's see what we can see with the linear probe. Notice that the linear probe is only good to 6 centimeter deep. Okay, so I can see adipose tissue, I can see muscle. Go deeper. Yeah. So I am going further down. So muscle. No, I wouldn't want penetration. I still like the resolution phase. Yeah. Okay. So muscle. The nerve got to be deep to that. Can you go to 6 centimeter deep? Okay, I see it now. So that's the nerve. I think, let's see, is it true or is it part of the muscle? Let's see. I'm tracing it up now. Yeah, I think it's promising. Now it's gone. I don't see it anymore. I think the struggle, even if I can see it there. This is lateral. This is medial.
Trying to find out in long axis, sir.
Pardon me?
Trying to find out in long axis.
Yeah, I'm trying to, but I'm not so sure the. So this is the long axis view.
Yeah.
So this is the nerve. So we can block it right there.
Some local. Are you okay with the local?
Yeah. So in fact, it's probably a split. Is it a split? No, it's still the one. Okay. So we can do it there.
Yeah.
It's much. Yeah, I will. Ouch.
Saline, please. This is saline.
I think my okay. Increase the depth a little bit. Artery. Nerve is right there.
Yeah.
Yes.
That's the artery.
That's the artery.
Are these the two components there? And this one for sure.
So right now, again, I'm not in the best position. That's why I'm struggling. She is struggling.
You want to stand on this platform? You think it will be better?
No, I think.
Better like that.
Yeah, I think it's right now.
You need to
Are
place
we
it.
still being taped? Okay, that's better. And usually I would obviously not use such a long needle.
Yes. Shorter one. 5 cm. Here. Attach the stimulator. Now it's seen there.
So we are going for the
Pop.
popliteal
Yes.
and
So this is a good demonstration of what not to do. I'm very close now.
this out of plane
I'm
approach.
doing out of plane approach. You can stimulate now. I'm sure you can.
So you look for the plantar flexion or the
Yeah, there it is.
dorsiflexion.
Yes.
Yeah.
Okay.
So you see the plantar
let's-
flexion. Yeah.
Give me half a cc there.
Should I give local now?
Yeah, give some local. You can drop the current. I'm going again with the hydrodissection. I'm still a little bit away. So my needle is there. So I'm just going at the, okay, half a cc there. Oh, stop. Okay, that is a very good illustration of some intraneural injection. Okay, so now I'm going to pull back and move the needle away from the nerve a bit. Okay, I'm looking at the needle.
That's the tip. It usually is seen as a hyperechoic tip.
Again.
That's the spread of the drug.
Okay, good. Inject a little bit more now. I'm on the lateral side of the nerve. Inject some now. Local anesthetic. That's good. So you see the needle tip there? I'm jiggling the needle. Can you give me a little bit more local again? Okay, good. Okay, so I think I'll continue the injection. I'm happy with the spread. Can you inject a little bit more? Because I look at the spread, you can see a local anesthetic spread around the nerve very well. So with this sciatic nerve, you still need a big volume. I find that if you use it for surgical anesthesia, sometimes 20-25 mils, you still have to wait for 30 minutes. So ideally, if I really want a fast onset block, I have to trace the nerve until it bifurcates. Then it will be a very nice place to give the local anesthetic and block both the perineal and the tibia. Yeah. Yeah, inject. Okay. It's nice. Oh, look at that.
Yeah.
You see the other one too. So that is a good illustration of one location. You have definitely spread to both nerves. Yeah. That's good. So again, a number of lessons. You see me struggle when you have a proximal block that you cannot really see well. Unfortunately, because this is external fixation is on, I don't want to put her on prone. Otherwise, I put her prone. I use the linear probe. I will trace all the way up. Right now, I'm not comfortable. She's not comfortable. So really, patient positioning and the operator position is very important. Decide where to do the block. You may have to abandon plan A, go to plan B, see where you can see the nerve best. And sometimes high up, proximal sciatic block, a nerve stimulation approach actually is as good because the ultrasound, as you can see, the image quality is not so good. It's hazy when you use the curve probe when you go deep. So those are the teaching points. Actually, this case illustrates a number of things that you don't want to do.
Thank you very much, Professor Chan, and thanks for demonstrating to us. A big round of applause to you. Thanks for being with us. And Professor Chan said about using a nerve stimulator to do a sciatic block as they get ready for the next case. It's a very simple way to do it.